Hello, welcome to the program. I am Omini Odan. The National Primary Health Care Development Agency was established to control preventable disease, open up access to basic health care services in the country, and to build capacities to achieve or create high-performing health workforce that would cater for Nigerian health challenges. Recently, Nigeria's Vice President, Professor Yemi Osinbajo, launched the Integrated Medical Outreach Program, which the National Emergency Routine Coordination Center is leading implementation of the modified Integrated Medical Outreach Program. The target objective of the Integrated Medical Outreach is to deepen and consolidate primary health care deliveries to communities in Nigeria, especially the underserved areas and the poor-performing local areas of Nigeria in routine immunization. Tonight on NTA Live, the focus by the expert is to explain the integrity of the program and how the various publics can queue into it to obtain the maximum benefits. But first is this background report by Basi Itaikbang.
An effective healthcare system is critical for any country to maximize outcomes and minimize costs. It is the first level of contact for individuals and communities in the national health system, making healthcare affordable and accessible to people.
You've been able to elaborate the Basic Healthcare Provision Fund, right, which is a fund that was appropriated by the National Assembly and assented to by President Muhammadu Buhari to reduce out-of-pocket expenditure on health by all Nigerians. We're now rolling out in all the states.
The National Primary Health Care Development Agency also has the responsibility of coming up with ways of limiting the occurrence and impact of diseases using education, immunization, and other proven interventions. Nigeria recorded a great feat in polio eradication. Does this mean an end to under 5 immunization?
Mr. President made the resources available, but he also showed statesmanship by coming up to encourage Nigerians to present their children for vaccinations. He vaccinated his own granddaughter and sent a clear signal all across the country that oral polio vaccine is safe. Right? And this was really the turning point that made us now coast across the finish line and eradicate white polio viruses. So we must continue vaccination to protect our children.
Another achievement in primary health care that is attributed to the commitment of the present administration is immunization coverage from 33% in 2016 and 2017 to 71% in 2020.
That is more than doubling it. That is unprecedented.
All these achievements is not without some challenges, some posed by the COVID-19 pandemic. Accessibility, public participation, health promotion, appropriate technology, and intersectoral cooperation are the agency's fight. Basi Itaikbang, NTA News.
Modified Integrated Medical Outreach in Nigeria is the focus of the program tonight. Welcome once again to the program, and it's Tuesday Live. At some point, our lines will be open. You put your call through, and please, if we join you, turn down the volume of a television set to avoid the holdback. Also tonight, you can be part of the conversation through our Twitter handle at Tuesday Live NTA. In the course of the program, to sustain the conversation on the issue tonight, we have reports across the country to bring us up to speed on where the issues and the concerns lie. Tonight, I have WHO country representative in Nigeria, Dr. Walter Kazadi Mulumbo. Welcome to Tuesday Live.
Thank you, Winnie.
Also joining us tonight is Director Disease Control, Immunization, National Primary Health Care Development Agency, and also representative of the Executive Director of the National Primary Health Care Development Agency, Dr. Basi Okpesun. Doctor, good to see you once again on the program.
Thank you. Good evening, Nigerians.
Joining us tonight also is Dr. Omotayo Bolu. She is Director, Immunization, U.S. Center for Disease Control. Welcome to Tuesday Live.
Very much. Glad to be here.
Okay, let's begin with Dr. Okposon. Dr. Okposon, looking at the modified integrated medical outreach, you hear new terms. Before now, we used to hear difficult to reach areas, but in this current effort, which is geared towards reinforced immunization in Nigeria, we hear words like unreached, underserved, and vulnerable communities dotting the landscape of 409 local government areas across 36 states of the Federation and the FCT. What does this imply?
Well, I think I want to first start by commending His Excellency the President of the Federal Republic of Nigeria, President Buhari, the entire cabinet, our team lead at the National Primary Care Development Agency, Dr. Faisal Schwab, all our partners that we have, them also represented here because of the support they are giving to the team for us to work with our state, our LGAs, to know where the problems are, to be able to plan towards solving the problem. Now, just to inform us that we have a center at the National Primary Care Development Agency that is called the National Emergency Routine Immunization Coordination Center. At that center, we have both governments and all our stakeholders in immunization, our partners, our donors, represented at that center. Now, when Nigeria recorded 33% coverage in 2016, and that report came out early 2017, which was the report of the Mixed NICS Cluster Survey, Nigeria recorded a coverage of 33% for Penta 3. I know any parent caregiver that has a child that goes to school, come back with a report card of 33%, will not be happy. And why I started by commending our presidents, our minister, and our ED, and our partners for this great effort is because when we recorded that low coverage in 2017, early 2017, unlike in the past, we just said, no, this was a coverage survey, we want to work with admin coverage. But the government then said, no, we are going to accept this 33% coverage, look at where the challenges are and be able to address so that we can provide affordable services to Nigerians. Based on that, we started some interventions, and since that period of 2017 early that we started implementing interventions, we saw the smart survey that came out early this year that is under validation now. The result that came out from that smart survey showed us something that is very good also, a country moving from 33% to about 71%. It is under validation. Once the validation is completed, we'll also still show back the report card to Nigerians. But even with the report, the government, under the leadership of the agency of the executive director, Dr. Faisal Schwab, and all our partners said at the beginning of this year, let's look at those areas that are not allowing us have 100% coverage like is seen in some other countries from survey. We did an analysis early part of the year, and that revealed 409 local governments in 36 states of the country that we need to give attention to, which led to the commencement of the Integrated Medical Outreach Program, which was launched by His Excellency, the Vice President, Professor Ibn Osibajo, on the 16th of March. And because of the COVID lockdown, we could not complete the activities. And with the COVID lockdown relaxed and the efforts from the agency, the ministry under the leadership of the minister and our partners, we are now set commencing the modified integrated medical outreach program. Meaning, just to mention and inform Nigerians, we want to commend so far there are about 14 states that the MIMOP started last week Monday on the 5th to 9th. In 14 of our states, the intervention has been completed. This week, as we are talking, another 14 states, the intervention is ongoing. And then next week, we have the remaining states That will also start on the 19th of October. And for those 14 states that have already completed last week, medical services were offered to our Nigerians in those facilities, in those 409 LGAs, free of charge. Immunization, maternal services, nutritional services, counseling for family planning, and the rest activities integrated were offered. I want to use the opportunity to thank the governors and the health teams in those 14 states that made sure in those last week the intervention was completed. And those states specifically are in the southwest, we had Lagos, Ogun, and Ekiti. In the southeast, we had Anambra State. In the south-south, we had Cross River and Delta. And then in the north central, we had Nasarawa and Benue State. In northeast, we had Adamawa, Borno, and Gombe State. And then in the northwest, we had Jigawa, Zamfara, and Kaduna State. These 14 state governors and the entire state team, we congratulate them. We appreciate the efforts that they made to ensure that they work with the federal to provide services to our people. And then the other 14 states that are offering the services this week, we are also appreciative for the support from those states. And we want to use the opportunity to encourage Nigerians, please, if you have a child under 2 years or a woman of reproductive age, please take them to the primary healthcare facilities near to you, and you will get services, primary healthcare services, offered to them free of charge. Thank you.
Dr. Okposon, still on you. Does this imply that out of 774 local government areas in Nigeria, if this program is centered on 409 local government areas, leaving out 365 LGAs, are they blacklisted? What happens to them?
They are not blacklisted. You see, the thing is, those other LGS out of the 774 that did not participate, at the point we're doing the assessment, the performance seemed to have been above average, and they just needed the basic support from the national, the state, and the partners to maintain their services. As we are doing the modified integrated medical outreach program in these 409 LGAs, the other remaining LGAs are still being supported to offer basic routine immunization services and also the RMSH plus N services for our pregnant women, our caregivers that go there for basic services, our children for nutritional services, and the rest of it. So those other remaining LGAs, it's not that they are very bad. They have been doing well, and we are still supporting them to ensure that they don't fall below the standard, while supporting these other 409 LGAs that we're not performing very well to also break up performance that is above average. Over.
Thank you for the update. Now, Dr. Molumbo, what's the WHO connection in all this?
Thank you for your question, Mr. Omoni. And first of all, I would like to express my appreciation for involving me in this program. As you know, the WHO has been working closely with the NPHCDA from the inception of this program. Our connection has been basically to support NPHCDA to develop the strategy on how to roll out this integrated program, outreach program, but also to develop the protocol that the health workers have to follow when they are supporting the communities to increase immunization coverage. WHO has also been engaged in funding for LGA supervision for these activities, but also directly intervening in the context of step-down training, at least in 21 of those targeted states. And of course, WHO is also helping NPHCDA to monitor this intervention, and particularly as it's coming at a very critical time with COVID-19 around us.
Okay. Dr. Omotayo, CDC US, can we also get your perspective? How connected are you with this?
Thank you very much for that question. So the United States Centers for Disease Control has been working with the National Primary Healthcare Development Agency for several years. We, in terms of the IMOP, We have worked with them from inception with all partners, including WHO, as Dr. Walter mentioned, as well as UNICEF and some of our implementing partners such as Affinet, to come up with the strategies for the implementation, the protocols and the guidelines. So we have teams working with NPHCDA at the national level. They sit with them on a daily basis at the National Emergency Routine Immunization Coordinating Center to come up with these guidelines and the policies of how do we implement it. What can we do to avoid pitfalls as we begin the implementation of IMOP? What are the things we need to do to have the highest number of caregivers bring their children out for immunization and primary health care services, as well as for mothers to receive basic primary health care services. In addition to that, we've supported the trainings both at the national level, state level, and at the LGA level. In particular, we've provided resources through the US government to support activities in Adamawa, Katsina, and Zamfara in terms of the teams that are going out to the field, that's the vaccination teams that are providing the services, supporting the training, monitoring of the activities, ensuring that the data that is collected as well is good data so it can be used for programmatic planning. So our team is right now out in the field supporting many of these activities from beginning to the end. And we will stand with the National Primary Healthcare Development Agency to ensure that even as these activities are implemented, we adhere to the best possible infection prevention control activities as well. So we're keeping an eye out for that as well. Thank you very much.
Okay, back to Dr. Okposon. Dr. Okposon, before we take the first reports, just a clarification on India. Dr. Omota has not talked about strategy for implementation. And this whole thing is a gamut of tiers, national, state, and the local governments. Most often at the national, properly mainstreamed, you go to state, quasi-mainstreamed, and by the time you get to the grassroots, the local government areas where we have the immediate link to the people, you find a disconnect from the perspective of some centers are not active, docility, lack of information. Has this been taken care of?
Yes, for this particular intervention, we had training at the national where we had participants from the states, about 14 per state participated, where we discussed the strategy that we are going to use. And then the LGA officers, representatives were trained at the state level on the strategies. And then the LGA officers that we trained, moving along with the state facilitators and the national facilitators, in turn trained the LGAs, health workers, and also community members. During the lockdown, I want to use the opportunity again to thank the Executive Director, Dr. Fisher Schwab, the Honorable Minister of Health, Dr. Henire, His Excellency, for the support they gave us to train these health workers during the lockdown. We work with our partners to train about 220,000 health workers and 90,000 community members on the strategies that we are using for this implementation and how they can work at their facilities safe. At the local government level, like you've asked, the strategy for the IMOP implementation was very clear. One, the fixed health facilities, all the primary healthcare facilities in the LGS, the 409 LGS, are to be open throughout the week of implementation. Every day, they have to open, offer services to Nigerians that come free of charge. In addition to the fixed primary healthcare facilities being open throughout the period, the second strategy was using the temporary fixed post, where we have large communities that have been identified within that LGA, but they don't have a health facility, where a team was provided to act as a mini health facility within that community throughout the period of the intervention to ensure that our Nigerians in those locations are covered. Then we had the third strategy of using the mobile teams. The mobile teams were to go to the hard-to-reach areas that under conventional method, they don't have a health facility, they are difficult to reach. And then we had team members that took services to those identified areas throughout the period of the intervention. So the strategy was clear from the beginning. The health workers were trained, the community members were trained, and then we used the community announcers to inform the members of our communities. And they were to start the activities at least a week to the implementation to inform the members of those communities of the services to be rendered, the dates, and the location that they are supposed to go for those services. So the strategy was clear before the commencement of the introduction. Thank you.
Okay, let's look at ownership and other perspectives. Dr. Motayo, when you look at a program of this magnitude, we talk about the mobilization now. If the people are properly mobilized, most countries today, Nigeria inclusive, are looking at thinking globally, acting locally. Now, if we are getting support from US CDC in terms of adaptability and adoptability, how is it working? Because you could apply certain principles, it's not adoptable in some localities. Are you thinking about this?
So that's an important and a great question in terms of adaptability and adoptability. Like Dr. Bassi mentioned, there's been quite a bit of training that has gone on with the teams from national to state to local government level. And each state varies somewhat. And so they use local solutions to manage the local activities that they're implementing. So if, for example, a state cannot start on a Saturday or feels that starting on a Saturday, you won't catch as many clients that you want, or it's better to start a program on a Sunday because mothers and children are going to church, so it's better to start on a Monday, then those will be applied depending on cultural as well as religious considerations. So each state would take into considerations that peculiar cultural, religious, and other peculiar activities within their state and the local government to adapt it to suit the situation. Do you open till 4 p.m. is when they're supposed to close? If they have to extend by an hour because people have gone for one religious activity or the other, they would adapt to suit the activity and the outreach programs that are going on, whether it's at the fixed post, the temporary fixed post, or the mobile post. Like the mobile post focuses on the nomadic populations, the hard-to-reach populations. So they have to adapt that mobile post to that situation in like some of the northern states where you have to think, how do we reach those nomadic populations? What kind of activities do we need to put in place? If you're somewhere in the south or where there's a fishing community or a farming community, you have to take into considerations, how do I reach those group of people? Is it best that that mobile post is out there early in the morning or in the afternoon? And so all of these considerations are taken into place as the teams go out. And even with our support, those are the things that our teams supporting them would also consider. So every state, even though they are slightly different, the general principle is the same throughout, but then it's adapted to suit the context within that state and that LGA. I hope that answers your question. Thank you.
Absolutely. Let's go to Dr. Mulumbu. The other aspect of it is understanding for deliverables. The experts have been trained by from the account of Dr. Okposon. But if the experts trained to go to these 409 local governments out of 774 LGS in the country do not understand it for deliverables, what M&E is in place to follow up?
Well, the good thing about this program is that it's taking place building on a success story. using the polio legacy. You know, through polio, the experts were trained on how to deliver different services to different communities. And there was already a monitoring and evaluation system in place, engaging the community from the grassroots and bringing up the information up to the central level. So using that, that investment, they were able to deliver different programs, different services based on you know, the gap that we identify in terms of coverage immunization, in terms of coverage of other essential intervention, nutrition, breastfeeding, etc. So when we helped the NPHDA develop the protocol, we also helped the NPHDA come up with a monitoring framework with clear indicators on how to track the services as they move along with implementation of the program. So it's a comprehensive strategy, taking consideration the input from the central level, the input at state level, the contribution of the LGA level, and the community themselves.
Okay. Did you have put into consideration what Dr. Notayo just explained, adapting and adopting?
Yes. The states are different, the LGA are different, we have to take into consideration the cultural dimension, and you know, we have to take opportunity of some of the, you know, the weekly market or the time where people go to church, and the religions and the particularity of certain region, what's the best time to go and deliver the intervention and monitor whether we are in the area where we have a nomadic population or whether we are among the elders. So we have to take that in consideration, and that's why this whole exercise is running quite well, although COVID-19 has come at a time when it can complicate some of the deliverable. So we were aware that we're going to face some of the challenges, but because there was a good framework put in place, we are able to track the intervention and deliverables.
Okay. Our lines are open, and our Twitter handle once again is @TuesdayLive NTA. We'll take a couple of reports, and when we return, we sustain the conversation on modified IMOP in Nigeria. Our first report is coming from Sokoto.
Immunizing children is a critical cost-effective strategy used globally to reduce infant and under 5-year-old mortality rate. Adoption and constant immunization of the children against the deadly polio virus recently ended cases of polio in Nigeria. In Sokoto State, experiences showed that 80% success has been achieved in the fight against the child killer diseases, maternal mortality rate, and acceptance of routine immunization and oral vaccines. These successes may not be unconnected with the involvement of traditional institutions and the clergy at the grassroots.
We have been having issues, not all the time, but when we have, we resolve it. So by and large, I can say the community is accepting the immunizations in Sokoto State.
Gage District Hospital was among community health care centers that championed the antenatal and vaccines acceptance in the state. However, communities in rural areas are still battling with the issue of accepting the immunization and oral vaccines.
Stakeholders need to be continuous strengthening capacity, educated, enlightened, and also invest heavy resources to ensure we prevent child, we prevent mother, and then we have healthy living in society.
Records available at the State Family Healthcare Development Agency shows that massive reduction in the maternal mortality rate has been achieved, while the agency says it is making frantic effort through enlightenment and sensitization at the grassroots.
Our next stop tonight is the report from Ibadan.
As the main thrust of bringing healthcare to the doorsteps of the Nigerians, this effort has achieved some gains over the last decade, with annual maternal deaths worldwide reduced drastically. Much of these gains are attributed to efforts focused towards specific illnesses responsible for the high rate of maternal mortality globally, saving an estimated 23.2 million children from death.
Because a lot of people carry our baby, they are not clean. A lot of things arise that we don't know the cause of it. But with the help of this vaccine, we overcome a lot of it. And we take it very, very important to avoid any unnecessary illness for our baby.
He had measles like a week or 2 weeks ago. So he has taken the first dose of the measles injection. So that is why that thing does not affect him that much.
Many people are aware of the immunization. They turn out in good number for the program. And presently for the routine immunization, all those vaccines are being administered. And formerly people are not coming in good number to receive the immunization, but there is awareness. People are aware that those diseases they are real.
The common immunization that we tend to give to these children to protect them, we fight against the issue of measles, polio, tuberculosis, even meningitis. Tetanus is one of the common diseases that we tend to revert. We have the diphtheria, pertussis, and tetanus, like I mentioned. So we have vaccines to be able to prevent all these diseases. If you are aware, you see that in the recent time now, Nigeria has been delisted for among the countries that are polio endemic.
Medical experts therefore noted that to avert premature deaths and disabilities in children, recommended vaccines should be taken with utmost priority for adequate protection of the children.
Our next up is OCA.
In its resolve to ensure qualitative and accessible healthcare services, the federal government initiated the National Primary Health Care Development Agency, NPHCDA. This agency partners the primary health care centers spread across the nooks and crannies of the country. Despite this policy, research shows that primary health care, which is supposed to be the bedrock of the country's health care policy, is catering for less than 30% of the potential patients.
It's a very great effort made. Even the IPDS, the immunization plus days, some of them goes with some packages, and these are what helped us to do what? To abate this issue of polio.
In terms of rating, it's 50%, because according to them, they said they need free drugs.
The federal government has remained committed to tackling the challenges confronting the primary health care service with quarterly disbursement of funds through the state's primary health care development agency. In Anambra State, some of the primary health care centers are striving to meet the health needs of the target beneficiaries, but hampered by inadequate personnel and other health facilities.
Health center, they are doing well, but all the equipment is not there.
We have challenges like we don't have security man who is supposed to be in charge of this place, and this because pregnant mothers not to be delivering here.
The National Primary Health Care Development Agency has lived up to its billings by bringing about a comprehensive health care to a majority of Nigerians, especially the rural dwellers.
Thanks so much for staying on the program tonight. And listening to the reports, let's go straight to Dr. Okposon. Dr. Okposon, listen to the report. Most times when we hear immunization, routine immunization, what really comes to the minds of most persons is polio, diphtheria, DTP3, and a few I cannot recall now. In this program, do we have selected focal ailments, or it cuts across all ailments?
Thank you for the opportunity again. Just to mention to Nigerians that during this MIMOP implementation, all vaccines are provided at our health facilities. This ranges from the DPT you just mentioned, the BCG vaccine, the oral polio vaccine, the pentavalent vaccine, the measles vaccine, the yellow fever vaccine, meningitis A vaccines. Every vaccine is made available Our children are assessed based on their immunization status and given these antigens free. And also to mention that apart from immunization services during the intervention, all other PHC services are offered at those points, that those LGS that are being identified for the implementation. We have pregnant women, women of reproductive age, are to go for their antenatal care free. They are to go for delivery in those facilities. They are to take their children for nutritional counseling and supplements to be given to them. Our men, our women, people that have minor ailments are to go to those facilities to be treated free in those facilities. So as long as you are in Nigeria, you are in any of those local government, the IMOB implementation is ongoing, because we see our banners everywhere around those local governments, and there are also jingles ongoing in those states and local governments to guide our caregivers. Please, they are to go there. And then just to add also, like the country rep WHO said earlier, the question you asked, whether we have any monitoring mechanism to ensure that the services are going on free. I just also want to add that before the commencement of the activity, we developed pre-implementation and implementation checklist where it will know the status of implementation, whether the estate was ready, and during this period of implementation, we know exactly where the states are. Like we mentioned at the beginning of the program, we have 14 states that are finished, we have 14 states that are ongoing, then we have the remaining 9 states that are to start next week. We also have monitors from the national, from the state, and the local government who goes around those health facilities to ensure that these services are rendered. The monitors also have what we call the ODK, where from the facility they are monitoring, they pick information and they feed back to the server, and this information is analyzed on a daily basis. Then at the local government level, from the ward focal persons hosts a review meeting with all the health facility in charges in his or her ward. The report from there is taken to the local government review meeting that takes place on a daily basis also. And same information is transmitted during the call-in data that was provided to our state and LGS and health facilities. We now receive on a daily basis the information of the services rendered in all the states that are implementing. So on a daily basis, we have information on what is happening at the lower level, and then working with our partners, we ensure that interventions where there is need for it are instituted appropriately, and then we know that, yes, these services are ongoing as it's supposed to be. And we really encourage our mothers, fathers, or caregivers who have children that know these children need immunization, who have families that have wives, sisters, mothers that they know need antenatal care and other services, those that know that they have children that need counseling on nutrition and other primary healthcare services, or minor ailments that need to be treated. All we are requesting and pleading with Nigerians is to avail themselves for these services at these designated fixed health facilities in those 409 local governments. Thank you. Over.
When we hear about vulnerability, it cuts across. Is there any special place for the elderly in all this, Dr. Boson?
For the elderly, initially, before the lockdown, we plan, along with these basic primary care services, to also working with the state and our partners to conduct medical outreaches, where our elderly would have been given special attention. Those that needed surgery would have been given free medical services, and a lot of other specialized services like the HIV, AIDS counseling, and so on, was to be included as a package. But because of the COVID lockdown and the fact that from experience, the medical outreach will attract crowds and situations where we will not want to see a spread of the COVID, the component of the medical outreach was dropped. And so those services like the surgeries and the rest specialized services that would have been rendered is not part of the intervention, which is actually why we now call it the modified integrated medical outreach program. Without that modification, it would have remained as the integrated medical outreach program. Aside that, our elderlies that have needs to go for basic checkup at the health facility during this period, for instance, we suspect maybe could it be hypertension or things like that, are encouraged to go to the health facilities for their blood pressure to be taken, and for those facilities that have the basic test for urine, those things will be done for them free. At least they will know their status as it relates to what their blood pressure looks like and other basic services. Thank you.
Okay, Dr. Motayo, very critical to this program if it is meant, and it is so, to improve immunization output in Nigeria. What's your impression about the cold chain across the country, or besides even across the country, within these 409 local government areas? What's your impression about the cold chain?
So thank you very much for that question. The National Primary Healthcare Development Agency has actually been working very hard with the Global Alliance for Vaccine Initiative, Gavi, as well as partners on improving the cold chain system in the country, from solar cold chain panels to having cold chain in every ward available. So in terms of the cold chain for these programs, there's been a lot of consideration given into that to ensure the viability of the vaccines. Every ward has some level of cold chain capacity to ensure that the vaccines are well maintained at the temperature at which they are supposed to be maintained. They all have cold boxes that they use to carry it. So if in a particular area or a particular mobile group, they would have their cold boxes where they can keep the vaccines. They have ice packs that are rotated as needed, and they have logistics to help change out the ice packs where there is need to change out the ice packs. So a lot of consideration and planning has gone into ensuring that the cold chain is sustained. So every ward, almost every ward, does have some level of cold chain capability. And where it's a far distance and they need to go with cold boxes, they take their the boxes, they have ice packs in them, and there are logistics teams that would help rotate out the ice packs as needed if it's not enough. So ice packs and blocks are built overnight to make sure that the vaccines are maintained at the temperature. Each vaccine does have a vial, has a monitoring code on it that you would know if it's no longer potent for use. And so they also monitor those on the vaccines. But in general, the cold chain is being well sustained for this particular program. Thank you.
Okay, let's go to Dr. Olubo. Dr. Olubo, now, statistically, the World Health Organization, as at 2019, global vaccination record shows that about 85% of infants were vaccinated worldwide by 3 doses of DTP3. Now, going by Dr. Boson's submission, what's your projection if the entire plan goes faithfully for Nigeria? Now, he has said that besides what we know, routine immunization, the focal ones, the regular ones like polio, I can't mention all now. If all this is taken care of and the plan goes in place, what's your projection?
Well, yes. As you know, Nigeria was part of the Global Vaccine Action Plan 2011-2020, which set a target of at least 90% of coverage in all the districts. And Dr. Posil mentioned that the latest assessment placed Nigeria around 70% of immunization coverage, with some disparities, and that was the reason why these 409 LGA were particularly targeted. So if all goes well, the NPSCDA has a target of reaching at least 80% in all of those LGAs, at least by end of this year, if all goes well. So it will be our duty to support them, monitor and troubleshoot when we face issues. But otherwise, I think Nigeria, if this program goes well, at least as far as immunization is concerned, Nigeria should be able to rectify and reach at least 80% in those LGAs. But at the same time, we need to ensure that the other LGA that were not targeted because they were doing well, we need to make sure they also continue to improve and maintain the target so that the country as a whole could reach that target. So the COVID-19, as I said, is still a challenge, and that's why we have this modified integrated MOP program to make sure that in addition to intervention, we make sure that health workers do not get infected and the communities are also protected. We are in it together, so I'm confident that if it goes well, Nigeria could reach the target as set up in the Global Action Plan to have at least 80% in all LGAs.
Okay. Key to this also is the place of data, and if data is properly put in place, it will inform planning, pre, during, and post. Now, WHO, looking at Nigeria, where we are in terms of primary healthcare development, are you impressed with the data available and data gathering? Are you impressed with it?
Well, you know, we have different set of data. We have the routine admin data, which report on what's happening based on different administrators. We also have data that we can gather from survey, you know, the independent survey. We're using scientific methods. And for Nigeria so far, in the past, we used to have a discrepancy between admin survey, admin data coming from LGAs and the institutions, and the survey. So sometimes we will have, according to admin data, high coverage, whereas when we do a survey, we find low coverage. So the challenge here is to try and reduce that gap, that discrepancy. And Nigeria is on course to reducing that. So because data from admin report are coming closer and closer to data or survey, which is the ideal situation. So for now, I think we have to try and triangulate, try to project some kind of average to know the situation and have a fair idea of where we stand, basically. And it's a continuous effort, and it's part of the intervention that WHO is doing to improve the quality of data so that we can have a fair idea of what's currently happening. And if Nigeria says we reach 80% coverage, we could reasonably give confidence to those data if they are triangulated by surveys.
Okay. Also in all this, Dr. Person, is sustainability. You start a process, and at some point it relapses because the sustainability gap was not properly firmed up. Now, 365 local governments are not in this because they recorded strikes. What is in place to ensure that there's no relapse as we are building on the 409 local government areas through IMOP?
Okay. Just to mention, before the IMOP, which was to specifically reach these 409 local government areas with the intensification for PHC services, we had in place, that is still ongoing, the optimized integrated routine immunization section, which was a strategy adopted in 2017, which the national, working with our partners and the state and the LGS, have been implementing, that gave us the leap we saw on routine immunization. Now, early this year, the OIRIS, which is the optimized integrated routine immunization section, was expanded to also accommodate the RMACH+N, which is the reproductive maternal neonatal services plus the nutritional services, were added to it, expanded, so that we are not just talking about immunization, we are talking about other PHC services integrated. So those services are ongoing in this, in all the states, and of course all the LGS in this state. The integrated medical outreach program was just singled out, the week was singled out to support the states to intensify the activities that are ongoing. So we'll continue to work with the states, we'll continue to work with the LGS and our partners with the outstanding support we are having from the national government to ensure that those strategies of optimizing our PHC services are being implemented. And apart from that, also, the PHC services optimization is the watchword for the agency for now, working with all our partners. How do we optimize PHC services? Those strategies are being developed, plans are on. By next month, there will be a PHC summit that will engage all stakeholders on the primary healthcare in the country on this plan on way forward, so that we are not just looking at routine immunization, but we'll be looking at other PHC services, offering optimized services at our primary healthcare center. And also to join my voice with what the country rep WHO mentioned earlier, you are concerned that you mentioned concerning data. We've had a lot of support from the government, and we've had support from our partners to ensure that the data quality in the country is something that is relied on. What are those efforts that are on? I will also inform you, opportunity to inform Nigerians that I think we are beginning to be proud of our country in a way. As we speak today, in 18 of the poorest performing states, when the mixed NICS result was released in 2017, early 2017, in those 18 states, we have a system in place, the SMS system, where we're supported by our CDC and WHO partners to ensure that we roll out those SMS projects in those states. On a daily basis, we have information on our server how many children are being immunized in all the health facilities in those 18 states. On a weekly basis, those information are gathered together, analyzed, feedback given to the states. On a monthly basis on the DHIS2 platform, we have information on what is happening in all the 36 states plus FCT. On a quarterly basis, we have information from our LQAS. Then on an annual basis, the SMART survey. Then every 3 years, the NDHS survey that comes in. Now, this result, the platforms, what we saw in 2017, early 2017, the gap between survey and admin data was about 73%. But as I speak, I think we are proud of our nation, the great work under the leadership of our ED, our minister, and all our partners. That gap that existed between the admin and survey, 73% as at early 2017, by the SMART survey that we are pending the validation, has reduced from the 73 to just 12% difference. And this is showing that we can see the admin coverages are dropping while the survey coverages are improving, and that gap has been widely reduced. So we have a near situation where at least we can see those data that come out can be used, are being used for planning and interventions being instituted. One of it is the MIMOB that we are implementing today. So we want to appreciate the national government and our partners for this support to bridge this gap, that we can have data that we are using as a country to plan over.
Dr. Omotayo, timelines matters most in this, and as a global partner, within your budget template, within your projection for achievements, given the challenge of COVID-19, are you worried about beating timelines?
Thank you very much for that question. COVID-19 really affected many donors and partners with regards to implementation of activities. But as you know, this is a global pandemic. And one of the things that we've quickly realized is we don't want COVID-19 to also affect the gains that have been made, so that when the pandemic is over, we find out that we now have low RI coverage or low primary healthcare service coverage. So for us at the US CDC, we recognized this and adapted very quickly to consider making sure that we restore and maintain and continue to support the RI services as much as possible. Where we needed to support COVID-19, we were able to move resources to support COVID-19 without affecting the funding and support for routine immunization and primary healthcare services. So yes, we did make some switches because of timelines like you mentioned, but we did not cut out the funds, and we found ways of extending those funds to continue to support routine immunization as well as primary healthcare services. And I believe this also is the same for quite a number of other donors and partners, to say if we can't carry out this activity, what are the things that we can do at this point in time, and what are the things that we can do later, knowing that we have targets and goals that we want to achieve. We don't want the COVID-19 pandemic to affect the gains that have been made. Dr. Bassi mentioned a lot of gains that have been made in routine immunization and primary health care. And even with the resources that we have, we keep pushing it and finding ways of supporting RI services, extending those funds so that the activities and the goals are still achieved. Thank you.
Our focus tonight, once again, is modified integrated medical outreach, IMOP. The program continues just after this time out. Stay with us.
Nigeria is a rich nation of green land, rich resources, countless crops and commodities sufficient to feed and provide a means of livelihood for her teeming population. Chin up, Nigeria, the giant of Africa. Exciting times are here. We can be self-reliant and grow our economy if we work together to explore our potential. It takes a whole nation. Let us get involved. Buy Nigerian to grow Nigeria.
For now, the best and most efficient way to avoid getting infected is through regular hygienic and sanitary practices, as well as social distancing. As individuals, we remain the greatest weapon to fight this pandemic. By washing our hands regularly with clean water and soap, disinfecting frequently used surfaces and areas, coughing into a tissue or elbow, and strictly adhering to infection prevention control measures in health facilities, we can contain this virus.
Coronavirus is real. Steps to avoid this pandemic. Wash your hands regularly or sanitize your hands. Keep social and physical distancing. Avoid crowded places. Stay at home unless absolutely necessary. Don't touch your eyes, nose, or mouth if your hands are not clean. Avoid the spread of coronavirus. Coronavirus is real.
NTA Tuesday Live, a network issue-oriented innovation talk show.
Thanks for staying tuned, and you can be part of the conversation through our phone number displayed on the screen, also through our Twitter handle at TuesdayLive NTA. While we went on break, a couple of tweets came in. Let's address this one, and I would love to get varied perspective from the panelists, starting with Dr. the WHO country rep who is here with us. Then we go to Omotayo, then we go to Dr. Basi Okposo. The tweet says, it comes from @Z20. Nigeria has just been declared polio-free, with the Boko Haram ravaging the north, with IDP subjected to living below normal. Do you think the worst hit places by Boko Haram were properly vaccinated before this declaration by WHO?
Thank you for your question. I believe all the children were reached through vaccination effort for polio because as you know, Nigeria has a different strategy to reach even others to reach areas. We have this strategy called hit and run, where some of our trained vaccinator were able to access highly insecure area, vaccinate children, and come back, come out of the area. So we have where it was really difficult to reach, we have a community informant living in an accessible area, and which we train, and we're relying on them to deliver the vaccine. So there were all sort of strategy to be relatively confident that all the children were reached, even in those areas with high insecurity.
Okay, Dr. Omotayo, how do you react to this?
Declaring Nigeria as wild polio virus free, with the eradication of wild polio virus. In the northern part of Nigeria, specifically in Borno, Yobe, and Adamawa, where we've suffered insecurities and several highly displaced persons, as Dr. Walter mentioned, several strategies were used to see, did we actually reach all those children? For example, geospatial mapping was used. We used what they call the GRASP, which is able to tell if a population does exist within a particular area that is very hard to reach. And with that geospatial mapping, they were able to measure the population numbers as well as number of potential children that are within those areas that are hard to reach. Through the community informants and security forces, they were able to go in and provide vaccination to those children once areas are liberated. And the geospatial mapping allowed us, through the GRASP process, to measure the target population. And so if you look at that data, you would see that from 2017, we had about 400,000 children not reached. By the time Nigeria was declared polio-free, we were down to about 20-something thousand potentially not reached with vaccination. In addition, the community informants, who are people that live within those communities, are able to identify whether there are children with paralysis. They're able to go in and provide the vaccines to those children. Also, once there's a liberation from insecure areas, there are teams waiting outside, ready to vaccinate those children. We had the strategy of eat and run, where vaccination teams would go in, quickly vaccinate, and then come out. They had the strategy of market vaccination, where you would carry the vaccines to the markets, to the farms, to make sure all the children were vaccinated. So there are so many strategies. I think Nigeria had one of the largest numbers of innovations of ensuring that every single child is reached with the polio vaccine, whether it was within the IDP camps, whether it was insecure areas, whether it's children that are not accessible for one reason or the other. We would use the most accessible individuals, community members, chiefs, security forces. They really helped. So we had strategies called the Reaching in Accessible Children, where you had security forces able to help with that. We had a strategy called, and we still do those strategies, which is also called REX, which includes reaching children using like vigilante groups and other security groups like that, who would help us go into places that are hard to reach so that every single child is reached. So a lot of work has gone into this, and the innovations that have been implemented gives us a level of confidence that all these children have been reached. And I can tell you that as part of the surveillance that is being done, we look for children that may be paralyzed, collect stool samples to test if there is polio in those stool samples, if you find any child that is paralyzed. And in the last 4 years, there has not been one child with the wild polio virus. And I say it again, the wild polio virus. Other things have been found, but not the wild polio virus has been found. So that gives us some level of, gives us that confidence that we have indeed eradicated wild polio virus from Nigeria. The one thing that I would like to make clear, though, is we continue with campaigns. The campaigns haven't stopped, please. Teams will still come out to vaccinate children, to give vaccines. So we can't say, yes, we've eradicated wild polio virus. Campaigns will stop. We will stop giving the polio vaccines. For now, those activities will continue. And we plead with caregivers, once the campaign teams come out, we would highly recommend that caregivers allow their children to be vaccinated. In fact, there is one that is starting next week in Sokoto, and a few others before the end of the year, where we'd have door-to-door vaccination. So we have to continue to keep our guards up, and we have to keep a good eye on surveillance to make sure we don't miss any potential importation. But also, we have to continue to improve the routine immunization coverage, which is everything we've been talking about tonight, so that as we improve routine immunization coverage, the number of campaigns we have to do is reduced. Thank you.
Let's leave it there for now. I believe Dr. WHO and US CDC have exhausted this. We'll take our remaining reports when we return. We'll follow up on other issues, starting with Dr. Okweson. We'll begin with Benin.
Health is said to be a critical factor in the promotion of development and well-being of the nation and individuals. This is why the Edo State government sees the upgrade of the primary health care centers as a catalyst in delivering health to its citizens.
This is nice. They don't waste time. You just come and take your treatment and you go. Okay. Yeah, and it's free.
I feel very great and I appreciate it. I feel very happy. Why? Because of the free treatment of immunization they are giving to our children, and they are very healthy. The
State Task Force on Immunization, chaired by the Deputy Governor, has engaged a series of advocacy initiatives. Dr. Julie Irabo is the Executive Secretary, Edo State Primary Health Development Authority.
You have the local government channel and many other stakeholders, religious leaders, both Christian and the Muslim. So involving these people into the task force, it means it's a holistic approach. We have what we call joint integrated supportive supervision, where the partners and the state team move to the facility, riverine and outreach on Keke, to ensure that the last child in Edo State is immunized.
Dr. Julie reiterates the state government's commitment in the area of funding.
Partners brings fund, we don't keep the fund. Prompt release of fund meant for immunization. That is part of our success story. Commitment from the government, from the state level, from the partners, and even up to the community.
The state government is hopeful that the challenges affecting most centers will be addressed.
Let's now go to Port Harcourt.
Before now, maternal and infant mortality have continued to pose serious challenge in healthcare delivery. With the institutionalization of the National Primary Healthcare Development Agency, government took up the challenge of lack of access to health facilities in rural areas by constructing primary healthcare centers in districts, towns and villages across the country. Since 2015, Rivers State government has continued to develop work plan for improvement in immunization against childhood illnesses, elimination of mother-to-child transmission of HIV, use of birth attendants, others including use of contraceptives for family planning, as well as breastfeeding and insecticide-treated nets.
We had measles, we have vitamin A, we had polio, and this last one we had a yellow fever vaccine. They are really turned up. In fact, we worked, men are really trying.
In our effort, we're even doubling our effort to make sure that no stone is left unturned on our primary to secondary and tertiary facilities, and encourage them. We thank God we have the political will because the governor is there supporting the health sector.
Findings show that there is impressive community response to primary health care issues, and beneficiaries speak on progress made through intervention health care programs and areas that need improvement.
Since I've been coming, they've always given me the one I came for, like the one I came for today, the 3 injections they gave to my baby. They have it, it's complete. It's okay. I bought my first baby here, so I like the services. As I take in again, I say I want to come and born here again. This is my second baby that I born here. They are taking good care of their pregnant women and their children.
The success story has been attributed to state funding and donor agencies' interventions that have impacted significantly on the citizenry.
Thank you so much for the update from Benin and Port Harcourt. Dr. Postina said after the break, after the report, will come to you. Now, when you hear immunization, routine immunization, what comes to mind is, are the people who are supposed to benefit from these services aware? Was the social mobilization strategy in place?
Okay. The routine immunization services are supposed to be offered at the health facility, where with the support they have from the LGA, they plan for the routine immunization, and the LGAs are being supported from the state and then the national. At all levels, beginning from the national, there are social mobilization working groups that design the messages to give, where our communication to the beneficiaries are clear. So we have at the national, for instance, the IMOB that we are putting up, and then for the routine immunization, there are jingles to inform our caregivers of the vaccines that are available and the uses of this vaccine. There are also communications to address rumors, for instance, in areas where we hear or the people don't accept vaccination. And then we also have the involvement of the community structure. Our traditional religious leaders have been very, very useful. You know, with the community engagement framework rollout that was launched last year, we have our traditional leaders, our religious leaders, our community members being involved in mobilizing the community. What we see is once the people understand what the vaccination is meant for, they take their children willingly for vaccination. So we try to involve the community members, our religious traditional leaders, to be involved and also appropriately inform the community members on the usefulness of these vaccines so that they can willingly accept. And then we also have in the community the town announcers who are being involved and engaged for passing messages to our community members on sensitive programs like the outreaches and so on. If there's going to be an outreach, the natural thing is for the community announcers to, first of all, 3 days to the event, start the announcement in that community. There will be vaccinations, and so the team will come, bring your children, they will give all the necessary information that is required. So engaging the community, engaging our partners, properly educating our health workers on what they need to do, and then providing the needed information that our Nigerian citizens need, it has really also contributed to the improvements in the uptake of vaccination. Thank you.
Okay, Dr. Motayo, let's look at the place of influence. This question is to Dr. Motayo. Influence. We need people to talk to the people. If you do social mobilization and you didn't talk about maybe change agent model or religious leaders or natural rulers, do you think if we leave them out completely, this work, and how best can be involved in this so that the people whose these services is supposed to be rendered to are aware of it, are aware of the benefits and the multiplying effects on the nation's health and economy?
So talking about influence, Dr. Bassi touched on some key points. And influence in Nigeria requires the entire village raising a child. It requires the northern traditional rulers is such a key influencer when it comes to routine immunization and primary healthcare services. Without the influence of the chiefs, the imams, the traditional rulers, the religious rulers, it would be a very uphill task if it were left just only to the healthcare workers to try to influence caregivers to see the importance of routine immunization and primary healthcare services and the need to bring their children to those services. So the influence of the northern traditional rulers is so key. The religious leaders, and even for the southern states, the pastors and the rulers have made such an important difference. And so they are key influencers. In addition to religious and traditional rulers, we also have to talk about the state governors and the state leadership. They also play an important influence on getting us to the numbers that we need to get to. Once they support, once they speak about it, once they encourage, different influencers have different impacts on different people. But I must also say that you journalists as well and TV presenters also make a difference, as well as those that work on social media, influencers, also make a difference. The words of one or two key influencers can turn things around in terms of improving coverage. So we require everyone helping to put the message out. Every word said by that mother, that father, that social media influencer, that journalist who play a key role in the role of primary health care and immunization is very key. So the influencers varies from different levels depending on your target populations and your target group, would make a difference to those caregivers on whether they bring their children for immunization or whether they seek primary health care services. So we target them differently depending on the population, the location, and the area in which they are in. Thank you.
Okay, thank you so much. Well, Dr. Mulumbo, where we are is like we're already there. There's no going back. We want in a couple of weeks, in a couple of months to start seeing results, as much as COVID-19 is just around the corner, but all effort to nip it in the bud is in place. So, in all this, how do you look at it if the wrong communication model is adopted in this?
Well, communication is very, very important in all this intervention, and communication should start from the grassroots, from the community themselves. The concept of primary health care used to be understood as, primary services, prevention, etc. But it's more than that. So engaging the community from the start, at the planning stage to implementation, it's very important. It's very important to create the demand from the community. They have to want the immunization services. They have to want nutrition services. They have to want the antenatal care services. They have to request for that. So if we work with them and they truly want those services, it's possible to streamline communication. And that's where the traditional leaders, community leaders, and volunteers come in. It's very important that we get the message right. Vaccines work. Vaccine save lives. If everybody is convinced that it save life, then they'll bring their children forward and get the vaccination. And these services, this initiative, it's not only about immunization. It's about all the services throughout the continuum of life course, as we call it. So we look at the children to support them to survive beyond 5 years. We look at the adolescent when they grow. We look at the mothers with the family planning services, with safe motherhood. We look at the elders, you mentioned it earlier on. But in all of this, it's important that it's buttressed by clear communication message so that we generate the demand. The community have to request those services. Then it will be easier. And we also need to fight misinformation because misinformation is the greatest risk in such a big campaign.
Do you have a structure like that in place already?
Pardon?
Do you have a structure like that in place already?
Well, there's a structure in place. We have communication specialists, both at UNPHCDA, within the UN. We have a UN communication network supporting different sectors of the government in activities they do. And for this particular initiative, yes, we do have a network of communicators, and we use different platforms to make sure that the right message is passed across.
Okay. Let's revert to Dr. Bassi. Dr. Bassi, it is so easy to start a process. As much as you have big partners like WHO, USCDC, and others I cannot remember to mention right now, do you foresee any challenge in terms of funding this initiative all through? Most often, you have initiatives like this where funding is like in a tripartite perspective. You have the agency, you have government funding, and maybe you have the federating states making contributions to the center for this to work. So how is the funding mechanism going to ensure total success without deviating from the principle of the entire program?
The structure we have on ground is helping the country a lot. At the National Emergency Routine Immunization Coordination Center, we have government representatives there. We have representatives from all our partners, the ones that are here and the ones that are not here, our donors. We have about 82-member team that we meet. When we plan interventions, we plan together, we implement together, we evaluate together. So during the process of development of whatsoever intervention we want to support the state and the LGA with, we are all in agreement in discussions. So there are some activities that are funded by the government completely. There are some activities that are funded by both the government, our partners, and our donors. For instance, the MIMOP that we are implementing now, we have government funding. We also have our donors and our partners funding some aspects of it. Like Dr. Bolu mentioned earlier, 3 states of Adamawa, Zamfara, and then Katsina. We had funding from and Adamawa. We had funding that came from CDC to support those 3 states. And then we also have some areas that are being funded by Gavi through the WHO. So all the interventions we plan for, we have the ones that are fully funded by government and the ones that we have our partners, donors supporting. I think the big issue is usually from the beginning of the year. We have an annual plan. And then we also have a comprehensive multi-year plan. So every year we develop our annual plan from that comprehensive multi-year plan. So in the comprehensive multi-year plan that we have also, it's already stated there what activity will be funded by government, what activity will be funded by partners, and then for the partners, who is funding what, and so on. And then within the year, when issues come up that were not captured by the initial plan, we also put our heads at the center together with what needs to be done, and then together we discuss how the funding comes. So for interventions like the MIMOP, I think all of us from the government side, our partners, have seen the usefulness of the intervention, and we all put our heads together to generate the funding for this implementation. Our appeal will be to Nigerians to avail themselves, the children, of this opportunity, and also to state that for the weeks of intervention that we are having, it's not just immunization that is offered at the health facility. We want our children to be immunized. We want our mothers, our sisters to be taken to the PSC facilities for antenatal care, for delivery services. We want our children also to be taken there for nutritional support. We want counseling for the people that have common ailment to be treated at the health facility, and consultations that they need to do. So let's avail ourselves of this opportunity, of the support we are having from the government and our partners, and stay healthy as a country. Thank you.
All right, Dr. Omotayo, most times projects like this activate this, what I'm going to say now, thinking global and acting locally. How do you juxtapose this in the success of this program for Nigeria?
Thinking global and acting locally. In terms of when you look at what NPHCD is doing with the partners, they are using all the, if I can pick your word, using all the global partners, the UN agencies, the international agencies, the bilateral agencies that work on health, especially as it relates to primary health care. They're thinking global in terms of it's not just routine immunization, it's all of primary health care services. So, talking about reproductive, maternal, neonatal, newborn services that could be provided either the fixed, the temporary fixed, or the mobile services. What of those global MPHC services can be offered? Taking the knowledge of the global partnership and experiences from other countries and adapting it for use within the Nigeria system, but also looking at what has worked and what hasn't worked, and what are the new innovative strategies that we can use using technology. So there's more use of technology to support some of these services, using ODK, using tablets to enter information on as we are monitoring the services that are being offered during this period. Thinking about the global activities that are being done in other countries that have succeeded and applying it to the work that we're doing here in Nigeria, as well as at the state levels and at the local government levels. So we're going from that high level approach, global approaches, global thinking of everything NPHCD and not just one service, and adapting it for use within each of the states and the LGAs so that we can have the most impactful program that would result in some increase in coverage and reduction in some level of morbidity and mortality. I must say here that, and I think Dr. Bassi may have mentioned it, the IMOP is not just this month. It's there's going to happen in November, it's going to happen in December. So there is continuous going out to the states over three periods to sort of intensify and improve those services and to ensure that mothers and children are referred to the appropriate service. Again, it's not just about the children, but the mothers as well. So it's all in all a global approach to ensure that we can make that impact at the local level, one step at a time. Thank you.
Okay, Dr. Mulumbo, now we have gotten to this stage, but we are looking at, no matter what, it said forward ever, backwards never. The program is moving, and what if midway the political will appears a bit deviated or relaxed? How will you jack it up?
Well, that brings us back to what you mentioned before, thinking global, acting local.
Okay. I just asked the question differently.
It's very important, you know. Universal health coverage, universal immunization coverage is first and foremost a political decision. It's very critical. Okay. So everything, you know, lies on the shoulders of the political, the decision maker. So it's very important. And globally, our head of state, head of government, they made commitment. We are about to launch the global immunization call for acceleration toward reaching universal health coverage, including immunization by 2030. This is the decade of acceleration SDGs. It has to be translated at the country level. It's not possible without the political leaders coming on board. We have committed as a world to reduce child mortality, infant mortality, maternal mortality by 2030. Today we have around 17,000 fewer children dying each day compared to where we were in 1990. Okay. But we still have more than 5 million children dying every year before they reach the age of 5. And Nigeria has its stake on it. We need to stop that. And for that we need, you know, political leadership. And here in Nigeria, in many ways, we are lucky to have that political leadership. And there is no reason for us to believe it will cease. Okay. We will continue to support through our different mechanisms, through our dialogue, as governing bodies meet, whether the WEDF Assembly or the UN General Assembly. Over.
Okay. Besides COVID-19, Dr. Obasi, one would have expected by now to see short takes, jingles, and other messaging besides what we are doing now about this whole initiative. Are we on that?
Yes, we are on that. Part of the efforts is the interaction and the opportunity you're giving us here at NTA to inform Nigerians on what is happening. There are other public service announcements that are ongoing. There are jingles at the state level, both television and radio, that are being sponsored to cover this activity to inform the people. And also at the national, we still have other line of activities with the Federal Radio Corporation of Nigeria to inform Nigerians of what is happening. So we have activities at the national, we have activities at the state level, and then activities at the community level to inform the people. At that lower level, the people will engage more at the community mobilizers who go around. Remember, I mentioned earlier about 90,000 of them were trained. And so they are also being involved so that people are aware of what is going on. Our encouragement and plea to Nigerians is we have the facilities. We have the primary healthcare centers. The states and local governments are doing their best. The national and our partners are supporting them. A lot of people are afraid of taking their words or themselves to the facility for treatment. Just to reassure Nigerians that with the training our health workers have received, our community members have received, they take proper care of clients that goes to this health facility so that they will not infect the patient, neither will the patient infect them. We encourage our caregivers to please make use of the primary healthcare centers for all PHC services because they are opened. We know there are so many countries that these facilities are not open, but in our country, the facilities are open, the government is supporting, the health workers are out there to do the work. And just 2 weeks ago, we had one of our global partners in one of the teleconference who made it very clear that Nigeria is the only country in the whole world since the COVID pandemic that is bold enough to commence supplementary immunization activities for its citizens, which is a plus, and we want to thank our health workers for this confidence they've had to be able to go out doing the work, and then our government and partners for supporting this initiative. We thank our president, we thank our PTF chairman, we thank our Honorable Minister of Health and our executive director who are not relenting, and all our partners to encourage our health workers to be out there to do the work. It will be a disaster if the services are there and then people are not going out for these services. So we encourage Nigerians to go out, visit the health facilities and get the required information. If for any reason you are visiting our health facilities and you have challenges, there are dedicated numbers that you can call. And these numbers, we will follow up with the state that incident takes place to ensure that justice is done. Maybe I'll use this opportunity to inform Nigerians. We have two numbers at the agency, 0803 123 0415. And then the second number is 0803 123 0416. These are numbers that you can call at any time and complain. And we promise you, with the ED we have, the minister we have, and the entire team at the agency and our partners, we'll follow up with those issues to see the best that we can offer in such instance. Thank you.
Dr. Motayo, still on communication is key here. Besides what is in place, what happens to those who are impervious? They are just difficult. People will say impossible. But these services is meant for them.
So thanks for raising that. And Nigeria has had a lot of experience with people that are resistant to either vaccines or the services. And so we've learned a lot, again, from using community influencers to speak, to influence people that are resistant to vaccine. We call them the vaccine resistant group. And so basically it involves using community leaders, working from within the community, influencers, religious leaders, as well as traditional leaders, to speak with these families or people that refuse services, to encourage them, to explain to them what the benefits are, what the impact it would have on the child, depending on what service it is they're going for, or for the mother, and to try to bring them to come over. So I'll give you examples we've seen in the field. Like in the field of polio, at one time in the north, there was a lot of resistance to the vaccine. And so it required the whole effort of pulling in the traditional leaders, educating them as well, taking them to see other countries that have similar beliefs and cultures, and also showing the impact of what this would have on them. And it was through that effort that brought about the change we saw in some states like Kano, that brought about a big change. In fact, Kano became one of the best states with uptake, in the northern states, with uptake for the polio vaccines. And it was through the efforts of those leaders. So we've learned a lot from the polio program, and we've applied that program to other services within NPHCDA within the routine immunization program, primary healthcare services, we cannot take for granted at all the impact that these influencers have, especially on the resistant group. We have them all over the world, not just in Nigeria, even in the US. And it's always using those influencers to try to get them to understand the impact and the benefits of the vaccines to reducing morbidity and mortality and winning them over so that they can begin to accept the services.
What we see most times as a problem has been quality of leadership, mostly at the local government level. Maybe you have chairman appointed at that level. They have appointees heading various fields. Would expertise, lack of expertise of particular appointee not affect this program? For instance, I'm a journalist and I'm appointed to head the health sector in my local government area. That requires understanding and even depth of knowledge. If this happens, and it happens in some locations in Nigeria, will it work?
Well, I think this is a very critical question. We have representation in all the 36 states, plus FCT, WHO or sub-offices. And one of the reasons we have that structure is to ensure that the human resource that are available for various programs is related to health, of the required background. And our role there is to work with the local government to contribute to building their capacity to deliver. So it's very important that we assess the needs. It's very important that we are able to frame the problem and present to the local administration, the Commissioner for Health, the State Governor's Office, with the requirement in terms of human resource for health. I mean, the appropriate requirement. And we believe if that is well articulated, it's possible to put in place the right profile to get the job done. This exercise is so important that we really need to get it right and put in place people that can actually deliver. Nigerian reputation is at stake, but it's about survival of people. So we really we are working together with NPHCDA and the local government to ensure that the gap in qualified human resource is met. It's an ongoing process, and we are in it with other partners, with CDC, with UNICEF, and others as well. Over.
Dr. Bassi, if I'm a Nigerian and I don't understand these services, but I want to also understand and get to know about it, are we online with all that is supposed to be known about IMOP?
Okay. For IMOP, recapping, I want to tell Nigerians is an initiative by the government with partners at the national supporting the states and the LGA to ensure that at the local government area, specifically those 409 that we identified to be poor performing, that during the period of intervention, every Nigerian in those local governments can walk freely into any primary healthcare facility in that LGA. You see the adverts on the banners, the jingles that are the state and local government are being sponsored to run. You go to any of the health facility. You go with your child. If that child is under 2 years, that child will be given the due vaccination. You go with your wife, your sister, your daughter. If that woman needs antenatal care, there for delivery, or related issues will be taken care of. A child needs attention nutritionally, that child will be taken care of. And the beauty is, during this period, for those services in all these LGAs, these services are supposed to be offered free of charge. And also, I know the question that may be in the minds of most Nigerians, which I'll repeat it again, is the fact that various states are at different stages of the implementation. It started on the 5th of this month. The first group of states, 14 of them, conducted the activity between 5th to 9th. I will come back to those states. There is a second set of 14 states. The activities are currently ongoing. And then there are a few remaining 9 that they will start on Monday. For those states that the activities are already completed for the IMOP, we have in the Southwest, Lagos State, Oyo State, and then Ekiti. They have finished the IMOP. It does not mean you shouldn't go to the primary health care facility for due services, just that the intensification, that the effort that are being added extra to ensure things happen will not be there, but the normal services will still be ongoing. In the Southeast, only Anambra joined in that first phase. In the Southwest, in the South-South, we had Cross River and Delta State that finished last week. And then in North Central, we have Nasarawa State and Benue State that completed. In the Northeast, we have Borno, Gombe, and Adamawa that finished last week. And then in the Northwest, we have Zamfara, Kaduna, and Katsina that finished their activities. Now, the remaining states, 14 of them are ongoing this week. So if you are not in these 14 states that you know the activities have been completed, then this week, we are today, on Tuesday, we still have Wednesday, Thursday, Friday, and so on will implement up to Saturday. So please visit the primary health care facility for these services, and it will be free of charge. And so the facilities are open. Please make use of the facilities. Don't be afraid whether you will get COVID in any of those health facilities. The health workers have been trained on how to handle patients. They are well aware. There are a few instances that things happen, and I can assure you from the feedback we are having at the national, because we have a national operations center that is monitoring what is happening on a daily basis. Every morning, we take an update of what is happening in every state. We have information of what is happening in all the states as related to this MIMOB implementation. We can assure you that the services are going on very smoothly. Nigerians are being treated. We don't pray for anyone to be sick, but Nigerians can walk in freely to any of these health facilities and receive services there. Thank you.
All right. It's more or less a coast home towards the end of the program. But before we end, Dr. Mutayo, I imagine you not wearing the toga of USCDC. And Nigerian government says, join the communication social mobilization team with Dr. Bassi to go to the field to convince Nigerians, now you're talking to Nigerians, why they must take this project, own it, and take it to heart, and not allow anything go in between for the overall healthy state of Nigerians. What will you be telling Nigerians?
So, first and most importantly is the impact that vaccines and immunization has on children. Immunization is actually the cheapest public health intervention that has the most impactful results. So my message would be, take the vaccines, get immunized, reduce the risk of your child getting infected or sick, either from polio or from measles or from diphtheria, pertussis, tetanus. These are low, very cheap interventions that prevents sickness and disease. and it helps to keep the lives of children so that they can reach their full potential. In addition to that, the IMOP includes not just vaccination, but antenatal care services, so that the mother who's pregnant can be examined to make sure her and her baby are healthy. In addition to that, we do have children with acute severe malnutrition. Services are there to support them, or referral to malnutrition clinics are there, so that those children don't die from kwashiorkor or marasmus. And so encouraging them to please bring your children out. The services are there. They are free. They would reduce the risk of infection now and in the future, because all these services many of them are preventive services. Get vitamin A for that child to prevent eye diseases. Get all these vaccinations to prevent any form of morbidity and mortality that children face. So my message out there is, come one, come all. Receive these services. They are out there for you for free. Protect those children now, because they are the future of tomorrow. If we don't keep them well and healthy, we don't keep mothers well and healthy to have their children, if they don't receive their family planning services so that they can space out their children, then we risk losing some of these potential children that can make a difference in society today. So that would be my message, to encourage mothers to bring their children, and also mothers to come for those services so that they can look after their children very well in the future. Thank you.
Thank you, Dr. Omotayo. Now, closing thoughts from the WHO perspective before we close.
Thank you again. Thank you very much for inviting us to take part in this discussion. What I would like to say is, with every crisis comes an opportunity. COVID-19 has revealed fractures in our system, but also the crisis helps us to come together and devise another course of action. The catastrophe that was predicted in Nigeria didn't happen. One of the reasons, the country as a whole, under strong political leadership, came together with a strategy to contain the risk. COVID-19 has impacted negatively on the services, but here we have an opportunity to catch up. So this MOP campaign, it's very important to catch up. It will help the country to get back on course and build back better. So we should not miss this opportunity. Thank you.
Thank you so much. Beginning with Dr. Bassey Okposon, Director, Disease Control and Immunization, National Primary Healthcare Development Agency. It was nice having you tonight on Tuesday Live. Dr. Olu, Director, Immunization, US CDC. We enjoyed your thoughts. Thank you so much. And to Dr. Walter Kazadi Mulubo, WHO Country Representative. Thanks for being on Tuesday Live. But just before we go, latest report from the Nigeria Center for Disease Control indicates that Nigeria has recorded 225 new confirmed cases of COVID-19. From the report, Lagos has 165 new cases, FCT 17, Rivers 13, while Anambra, Edo, Ekiti, and Kaduna states recorded 1 case each. This brings the number of total confirmed cases to 60,655, discharged 52,006, with 1,116 deaths. That's the update on COVID-19, and that brings us to the end of the program. Thank you so much for your tweets, and we believe you had a good time with us.